Okay, why do we do brain death testing? What is the need? Anyone? Yeah. Why? Normally, as you know, things stand. Every time we talk about death, we think when the heart stops or you stop breathing, that the patient is dead. But we know now that that doesn't hold true, especially with all the vital signs that you can maintain for prolonged periods in current ICUs with modern technology. You can keep a patient alive though he's brain dead because you have a heartbeat and you have a blood pressure. Is that right? Okay. So conventionally, there were two distinct mechanisms of death recognized for a long period. One was cardiac arrest or a respiratory arrest. In 1968, the ad hoc committee of the Harvard Medical School was set up to examine the real definition of brain death, and that's when they renamed brain as an arbiter of death. Brain death was first described in 1959. Like I said, the need was there because all the concept of brain death arose from the awareness that just cessation of respiration and heartbeat were obsolete criteria for death. Because in our modern era, with all the technology that we have, we can keep a person alive even though he's technically brain dead. So why do we need to define if a patient is brain dead? I've already put up the slide, sorry. So when you clinically suspect that a patient is brain dead, and you're still going on with all the expensive treatment, the drawbacks are, when treatment seems futile, what are you doing? Your, resources are expensive, so there's unnecessary costs involved. Relatives are always very, very much stressed. They go through the agony and anxiety of not knowing if the patient is going to be well or not. And of course, there's always false hopes, and that is also a big stress on the family. And especially in India, where you don't have Medicare or the government's looking after your medical expenses, then, it's also a real financial pinch for the patient's relatives to foot all the bills in ICU, which is expensive, as you can understand. And of course, another important point is, once we know that a patient is brain dead, then we can always start talking with the family in terms of organ donation, which is so important in today's era. We know, as they say, that, don't take your organs to heaven because God knows we need them here. So it's important for all of us as practitioners in intensive care to talk to family when you know a patient is brain dead, to try and see if they are agreeable to donating organs, and that's where brain death definition comes in. So how do you define brain death? Let me go back. Can someone define brain death? Next, any gentleman here? Yeah? Okay. So it's actually defined as an irreversible loss of all functions of the brain. So it's not just cortical functions, more importantly, brainstem functions as well. And the diagnosis is primarily clinical. No tests are required if a full clinical examination, including 2 assessments. So normally, in most parts of the world, and I'm sure in India, 2 assessments of brainstem reflexes are needed at a gap of 6 hours. And of course, you can do a single apnea test. So if this is done, you really don't need to do more tests unless there are reasons to do so, and we'll come to that. So when we're defining brain death, there are 3 essential components to it. First, you need coma. Second, absence of brainstem reflexes. And the third thing is there should be apnea. So the patient should be in apneic coma. Another prerequisite is the patient should have structural brain damage as demonstrated on any kind of imaging that you've done, a CT scan, an MRI, but you do have to have a structural brain damage. So you could have an intracerebral hemorrhage, you could have a severe traumatic injury, you could have subarachnoid hemorrhage. So there should be some structural brain damage. So you have to identify an underlying disorder that led to the condition the patient is in. Then coming to, before you start doing the tests, there are certain important things. What would you want to rule out? I've given a clue there, but what other things would you like to rule out before you start testing a patient? One by one. One answer from everyone. You there? Would you like to say, like, what would you like to make sure before you start doing the test? Anything that can mimic death, right? So I'll just go through that for want of time. So you want to make sure the patient has not received any depressant drugs in the preceding 24 hours or 48 hours, depending on the drugs you use and how long they stay in your system. The patient should not have had neuromuscular blockade. The patient shouldn't have shock, hypothermia, anything that will affect the brain function and give you signs which might lead you to think that the patient could be brain dead. Then there are a lot of metabolic and endocrine disorders which can mimic brain death or lead you to believe that, the patient could be brain dead. And that's a whole list of it, and you'll find it in all the textbooks. So since we're going to just discuss the criteria of brain death testing, I'll just quickly go. So any form of metabolic coma, maybe diabetic ketoacidosis, hepatic failure, endocrine disorders, mixed edema coma. So you just got to make sure that the patient does not have any of these on board. Brain death can be tested technically within few hours of admission. So if you get someone who's been in a very severe MVA, a road traffic accident, and he's got a serious brain injury, the test can be done clinically within a few hours of admission, so you don't have to wait. But normally we do tend to give the patient, unless it's really futile, 24 hours in ICU just to get the family, sort of accept the reality. But it can be done within few hours of admission. Like I said, it has to be done by 2 independent intensivists, ideally. That's what they practice everywhere. And they should be done at 6 hours apart from each other. All the documentation is done on a format that they have, and so all the tests have to be documented. They're usually done by a senior intensivist or a consultant in ICU, at least of experience of 5 to 6 years in ICU. And of course, the person who's going to be doing these tests shouldn't be involved in organ donation programs or shouldn't be involved in actually doing the transplants. Like I said, 2 sets of tests are recommended to ensure irreversibility. In the US, loss of brainstem reflexes. In addition to that, you do need to have an isoelectric EEG, so you have to demonstrate absence of cortical activity. In Europe and India, I think brainstem death is probably adequate. And I have Dr. Singh from the UK. Is that clear? Now, what do our clinical tests do? These demonstrate the absence of brainstem reflexes. So all our tests are sort of compiled just to prove that the patient's brainstem is not working. And of course, you have to prove that the patient is not spontaneously breathing. And for that, we do the apnea test. These tests should always be performed when you have made sure you've excluded all the criteria we've talked about. Sorry. So we do a set of cranial nerve examination and we do the apnea test. Now, does the next person want to talk about the cranial nerve examination, which is the first one you would test? Anyone? Okay, so the first one would be you would look at the pupils and see if they're reacting or not reacting. What do you need? When would you say that, this is a positive pupillary test? When the pupils are fixed and dilated. Yeah. So absence of a pupillary reflex, which is testing your optic nerve and your oculomotor. Then the next test is the corneal reflex. Can someone describe how you're going to do a corneal reflex? Anyone? This side? How do you do a corneal reflex test? Yeah, you can use a swab of cotton and gently, yes. And what would you look for? Okay, so there's no corneal reflex. And this is testing your trigeminal and facial nerve. Facial pain, how would you do that? Very simple. You can apply deep pressure on either the maxillary sinuses, the forehead, preorbital region, and make sure there is no facial pain felt. Next, you would do a gag reflex or a gag test and a cough reflex. How can you do that? Gag is easy to examine. Take a tongue depressor and touch the posterior pharyngeal wall, and you will see that the gag is absent. And how do you elicit a cough reflex? The patient's on a ventilator. So put your suction catheter through and see if the patient is coughing. The next test is the oculovestibular reflex. We're testing that with the help of the caloric test. And does anyone want to tell us how to do the caloric test? Anyone? How do you do the caloric test? There were 2-3 people who were already doing these tests in their ICU. So how do you do a caloric test? What do you look for? Okay. How do you do the test? What are the prerequisites? Ideally, before you even do the test, you should use an otoscope to make sure the tympanic membranes are intact, that there's no perforation of the drums. Then, once you've done that, make sure there's no wax in the external auditory canal. And then you use 50 cc's of cold saline, which with the help of a thin cannula, you inject slowly into each ear, one after the other, with maybe a 5-minute gap. How long would you observe the patient? Suppose you've instilled the water in the right ear, how long do you instill or look for the positive? Wait for at least 5 minutes after you've injected. You don't get it immediately. And then you go to the next ear.
Madam, is there any utility of dog?
Sorry? It's not mentioned in the list, but of course when you look for brainstem signs, that's the first thing. That is the first thing that would tell us that the brainstem is not working. When you're even before you're doing the test, when you start to skip. It is. But Doll's eye is something we would look at, even before you officially, but it's not mentioned in the list that, the criteria. What would you think, Dr. Singha? Are you including it? Doll's eye is not included really in the list.
Not, we do it, but
yeah, but we do it routinely in ICU anyway.
It's not part of the prescribed test.
Okay. Who wants to describe the apnea test? How do you do it? What are the prerequisites? Anyone who's done it before? I can see Shilpa. Maybe Shilpa will tell us. Do you want to tell us how to do the apnea test? See, basically, before you start doing the test, what are we going to look for? We want to make sure the patient is not spontaneously breathing. Now, you got a patient who's brain dead, who maybe is post-cardiac arrest, any or maybe an ICH, is connected to a ventilator, so he's being ventilated. Now you're going to disconnect him from the ventilator, but you have to make sure that his vitals otherwise are all normal before you do the test. So his oxygenation should be adequate, so pre-oxygenate the patient with 100% oxygen till you can see that your SATs are, in the normal range. Make sure the hemodynamics is normal, so these patients would have an outline, so make sure that your blood pressures in the normal range. Make sure that the patient does not, has normal temperature, is not hypothermic for any reason. Make sure the fluids are optimized. Like the patient, otherwise, besides the brain, is well optimized. Rule out any sedation which the patient may have received in the preceding 24 hours. Sometimes some drugs can linger longer if you have renal failure on board, so you'll have to wait longer in these patients before you do this test. Of course, no muscle relaxants on board. Like I said, the patient should be pre-oxygenated with 100% oxygen for at least 10 minutes. It's a normal practice to do a blood gas before you start doing the apnea test, and that for one thing you want to make sure the patient's oxygenation is normal and CO2 is in the normal range. And it's also to make sure, because these patients are all on an ETCO2 monitor when you're doing the test. So you want to make sure there's a correlation between the CO2 on your blood gas and what the ETCO2 is showing you within an acceptable range. Then you disconnect the patient from the ventilator, but you have to make sure that the patient gets oxygenated. So how can you do that? Use the oxygen tubing that you normally would use. It's something like a suck, the oxygen tubing which you connect to your mask, and then that should go inside the endotracheal tube and give him high flow oxygen. Make sure your SATs are in the normal range. So the patient should not be hypoxic, though you have disconnected the patient from the ventilator. So I've written here 5 to 6 liters, but it should be anything that you need to keep the oxygen in the normal range. And of course, monitor the blood pressure. And then you observe the patient for spontaneous respiratory effort. If there is no respiratory effort, like you've observed the patient for at least 5 minutes, you see there's no spontaneous respiration at all, then you know that the patient's apneic. So you take another blood gas, because what we want to make sure is the CO2 is above at least 60, depending on what the baseline was. And this is to make sure that, hypercarbia, which is also a stimulant for your respiratory drive, is there and the patient is still not breathing. Once you've done the test and you're certain that the patient's apneic, connect the patient back to the ventilator. What is the Lazarus sign? Does anyone know? We've done a set, like we think the patient's brain dead. We've done all these cranial nerve examinations, looked for pain, we've done the apnea test, and we're pretty sure in our minds that the patient is brain dead. Sometimes what happens is, though a patient is brain dead, you can get some reflex activity, which is spinal automatism. So maybe some movement, which is an abnormal movement in the limbs, sometimes some head turning, which cannot be explained, but these are reflex movements, and you should not really be worried once these tests are positive. There are supplementary diagnostic tests that you can do. Normally, if you've done 2 sets of clinical tests that we've just discussed and the apnea test, you don't need to do more supplementary tests. But in certain conditions, suppose the patient is hemodynamically unstable, then you know that you would probably want to have some additional information. And then there are tests that you can do. Though the clinical tests are the gold standard for assessment of brainstem function, there are some tests as surrogate markers of cortical function. They are not 100% specific or sensitive, and they're usually recommended as a confirmatory rather than an absolute. So your brain death criteria have to be met with, So these are additional tests to confirm cortical death. So the indications for doing confirmatory tests to diagnose brain death: one is if you're not sure there's a cause for the coma that the patient has. So you've done a CT scan and you can't find a structural lesion, so you don't know why the patient is comatose. If there's cardiorespiratory instability, so you can't do an apnea test in that sort of scenario. If there's a possibility, there's a drug, which is lingering on, the patient's got renal failure, you've given sedatives, and you're worried that they may still be lingering on, or there's some metabolic parameters which are abnormal and you're worried that they may be affecting the brain as well. For some reason, if you can't do the cranial nerves testing, sometimes if there's a cervical cord injury, again, if you can't do it, then you can go to these supplementary tests. And the first one that we think about is the 4-vessel angiography. This is a proper angiography, invasive. Patient's taken down to the angio suite, and you look at the vertebral and the carotid arteries. So if you don't see any flow in beyond the foramen magnum, then you know the posterior circulation, there's no blood flowing through there. And if there's nothing beyond the petrous region, then you know the anterior circulation there's no flow in the anterior circulation. Sometimes if there's a residual flow, you can see a small trickle, then you can't diagnose brain death. You'll probably have to repeat the test again. So these tests may therefore produce false negative results, and particularly likely in the presence, maybe if the patient's got decompressive craniectomy, a skull fracture, sometimes it's difficult to interpret these tests. So that's the 4-vessel angiography. You inject a contrast, look at the vertebral and carotid artery. So you're looking at the posterior and anterior circulation, and you won't see any flow. Now this is an invasive test. It's time consuming. You're taking a very sick patient, unstable patient down to the angio suite. Sometimes it's an easy procedure, quickly done. Sometimes it takes time. And most importantly, maybe not all centers have this facility. So these are the drawbacks. You can also do an MR angio or a CT angio. It's non-invasive, but it has the same drawbacks like the formal angiography that we do, that maybe not all centers have these facilities available, Maybe it's not, and it's expensive as well. Transcranial Doppler, it's being used in some sort of centers more and more, but again, you need a person who's really, really expert in doing the transcranial Doppler. It's non-invasive, it can be done at the bedside. You look at the blood flow through the middle, cerebral, and the vertebral arteries, and that's compared with that of the extracranial vessels. Typical findings that you would see on a TCD after brain death, it's said to have a diastolic reverberating flow. I've seen it, but I can't describe it because you have to be really expert in doing this. So there's a diastolic reverberating flow, and there's little or no systolic flow, which is seen. Again, the TCD has a sensitivity of 91 to 99% and 100% in skilled hands sometimes, specificity. But the technique has significant operator dependence. Previous surgery or the presence of a ventricular drain may make the waveform interpretation difficult. Then there are a lot of new tests which are coming out with the help of newer technology. And so you can do assessment of brain tissue perfusion. So there's a contrast enhanced CT cerebral perfusion. You can do a single photon emission. It's like nuclear imaging, single photon emission, computed tomography, positron emission tomography. These are mentioned in the books, but I've really not had any experience with it. Then coming to physiological assessment, not everywhere do they insist on having an electroencephalogram, but this is a widely used confirmatory test. However, a specialist expertise is required for interpretation. Artifacts from all the equipment in intensive care can sometimes make it difficult. So if you find an isoelectric EEG, then it is suggestive of cortical death. A confirmatory EEG is mandatory in many European countries. It is strongly recommended because loss of whole brain function can be demonstrated. So you've done the brainstem reflexes testing and you do an EEG, so you've demonstrated there's no cortical activity or brainstem activity. Then there are tests that are described, but I have not seen them being done for brain death testing. But you can do the somatosensory evoked potential test and the brainstem auditory evoked potential test. They demonstrate loss of functions of various afferent pathways of the brainstem. I don't know if they're practiced anywhere. In the unit I worked in abroad, they never. I don't know. Dr. Singer, would you be doing these tests? No. Okay. So they are there. Can be used. Now, last word. With children, you have to be a little careful when diagnosing brain death, especially those who are less than 5 years of age. The general criteria are same as for adults. Only thing is you give them a longer period of observation. So we are doing a test, say 6 hours apart. You give them maybe 12 hours, 24 hours, even 48 hours. And of course, you would use tests like the EEG in kids, and maybe a cerebral angiogram as well. So if the age group of the child is 7 days to 2 months, then you give them a period of 48 hours. If the child is 2 months to 1 year, at least 24 hours. And it's not recommended for preterm and those less than 7 days old. So that's about it.